My name is Johan from UPM. Today we're talking about biomechanics of extfix. This is the outline of my lecture. Extfix by default should have pins traversing the skin and all the way to the bone, and the frame of its construct must be outside the skin. So this is the usual extfix construct. Of course, it has some historical value to it. The concept of hospital gangrene forcing the surgeons to minimize the number of implant in the soft tissue, hence the development of extfix that we see today. Just an emphasis that how important biology of the fracture healing is. No matter how good the construct or how good your fixation, if the biology is not taken care of, your fracture will not heal. Okay, so extfix is good. It takes care of the soft tissue well. Okay, and we all of us need to know because it's junior MO kind of level lah. Basically, this extfix, anybody can do it at 2 a.m. in the morning in emergency OT. Hence, we need to understand some biomechanic basis behind what we are going to perform. And because the biology is so important, always correlate your biomechanic knowledge with biology, which is still of utmost importance. Otherwise, it just be a monkey see, monkey do. We see our senior do extfix. Okay lah, next time we follow like that also. But not understanding the mechanics or basis behind it. And if we see the normal, usual extfix construct, okay lah, we may not be faced, or we might be okay lah, biasa lah ni. But when we see something more complicated, then this is when the biomechanic knowledge comes in also, so that we can decide whether these are sound or not, whether this construct is okay or not, whether this so-called pinless fixator, is it biomechanically reasonable or not, whether this unusual construct done by this surgeon, is it actually okay. Usually we don't do like this, but is it biomechanically superior? It probably is. Or whether this Elizarov on the spine or skull, biomechanically, is it okay? At least we have some idea lah. Now, we can divide extfix into pin or ring fixator type. Alright. Generally ring fixator is more stable because it can resist all these forces, these deforming forces to the bone displacement. It can resist it better compared to a pin fixator that we are familiar with. Okay, but of course not everybody can confidently apply a ring extfix. Okay, think of the pin fixator as a cantilever mechanism where the fixation is over here and the load is over here, just like an extfix. So naturally it's less stable compared to a ring fixator where a patient can walk on it if applied correctly, can even do workout. You search YouTube, you will see all these videos. You can also divide the extfix type by means of whether it's unilateral or bilateral, or whether it is a uniplanar or biplanar. Obviously, biomechanically, bi is better than uni, whether it's plane or laterality. But always consider biology first, I said, right? Because fracture will heal if the biology is okay. How can you apply this in all anatomical position? Not possible, right? Not all the place you can put like this. So correlate that with your biology always. Okay, and this is where modular frame is good. Modular extfix, because it allows more freedom of pin placement and it offers easy reduction. So in the end, you can do faster. Probably slightly more components and rods needed, as probably less rigid construct will be built, but we can always supplement it with more rods if it is again biologically acceptable and also resources allow. Very nice you can do modular ni. We know the use is substantial in a pelvic extfix, where we pasang here, pasang there, and then we shoot II, and then we close the open book, and then we tighten the clamp, BP stabilize, and we have that satisfying reduction. So modular is easy that way. And see how good it is for biology. You can't put pin in all the same plane. Not all the time you can do that. If you have modular, you have more freedom. If you have modular also, you can also avoid this problem, because we know if uniplanar simple, you put far and then you put near. And what you need to do, you need to keep it reduced all the time. But always what the problem is, after putting all the 4 pins, it is not well aligned. So what you do, you just shove the clamps and you shove the rod and tighten it in this position. What will happen subsequently, because the pin bends, it will loosen on the cortices here. So modular extfix will avoid this problem. Now this is the important bit, because this is the opening Viva question that we got during our final exam 2019. Alright, how to increase the stability of extfix. Probably you should take home this one only method of increasing stability. Alright, so what you can do is reduce it nicely and get a good fracture end. Not always possible in comminution, you can't get. Alright, not of utmost importance. If you can get it, you get it. If you can't, it's okay. Alright, biology takes precedence. If you take too much time to reduce it, too much effort to approximate it, it's not worth it. Important is pin placement, near, far, as much as possible. So the left side is good lah in these pictures that I'm going to demonstrate. Bigger pins is better, more pins is better, more rods is better, bigger rods is better, rod closer to bone is better. And last but not least is multiplanar rod is better, or multiplanar pin is better, as far as the biology allow. Okay, alright. So consider what you have. If you have, you can't just simply choose your pin size. If your element can only accommodate 5 shunt spin, you can't just go and use 6. I've learned this the hard way. So consider what you have also. Consider the elements that you have. Last time I did modular extfix when I was on call, and I'm so proud of the construct. But the next day the specialist comment, apa pakai banyak sangat ni, apa elemen apa semua ni, kita dah letak banyak dalam OT. So consider your resources also, faham? And last but not least is the biology of the construct. If it's too difficult to reach the wound, too difficult to do dressing, it's probably not worth it to add all those extra pins and rods and all that. But again, I need to emphasize the importance of choosing a big diameter pin whenever possible. Moving on to components of the extfix. I put this on because there is some discussion about pins where we can play around. The most important are still all these factors that you can answer, but if you want, you can add on to this if you can understand the concept. Now pins or shunt pins or shunt screw is a modified cortical screw. The good thing, it has a larger core diameter compared to a normal screw. So in a way, it is superior to a biasa punya cortical screw. Long shaft for you to apply all the elements and rods. But when it comes to purchasing a bone, take note that if you put the thread in far cortex and the near cortex as well, the diameter of the core diameter over here is still small compared to, for example, just now is 4.5. It is small actually. So what is acting here is only 3.4, making it more prone to bending failure, as opposed to if you purchase one cortex only, far cortex only, and you let the smooth shaft of 4.5 being in the near cortex. So it will exert a better resistance to bending forces. This is one point. Number 2 is the concept of using a tapered shunt spin whenever available or whenever you can, in order to get what we call a radial preloading. Alright, meaning we purposely misfit the near cortex with a bigger diameter punya implant, okay, so that as opposed to the tip, so this one will sit in the near cortex, right, and this one sit in the far cortex. You drill same, you drill the small drill bit to accommodate this, but when it comes to the near cortex, as you screw it in, it will accommodate a bigger core diameter, or this part of the pin which is bigger, and purposely oversized a little bit for it to exert a radial force through the hole. Okay, you see this arrow, pin in the middle, radial force. The concept is when you load the pin with whatever force, it will distribute the force nicely around the hole. Okay, push it the pin this way, it will distribute the force nicely, so it will reduce the incidence of loosening. Usually ngam-ngam kan, betul tak? The normal shunt spin that we use, if you don't preload it, you push one way, it will loosen this part, it will gap this side, it will produce a osteolysis and all that. That's how your pin loosening comes, on top of infection, of course lah. There's also a concept of axial preloading, where in a segment of bone, you purposely push the pins together or push the pins away in order to exert some force here, and this will contribute to the stiffness of the frame. Generally, it will increase the stiffness. Study says radial preloading is better than axial preloading, but will you do this 2 a.m. in the OT while doing exfix? Probably not, but it is something, a concept that you can know that it exists lah. If you don't understand it, it's okay. Don't answer this in Viva, or else you can dig your own grave. If you're confident with your understanding, you can go ahead and add on to all these factors that I mentioned to you earlier. But these are more important than the pin punya factor lah, I would say, in my opinion. Or else you just get confusion and confuse the examiner. Just a bit additional point about ring fixator. Ring fixator sounds more complicated, hence more factors you can play with. In the end, it's the same with all the factors I mentioned just now. The stability over here, tapi it has got a few more special additional factor. For example, when you tension the wire, you must tension it, and adequate tensioning will improve the stability. You know that when you tension, you can get this nice twang, satisfying sound. And if you want to avoid this ring from toggling like this, bending like this, you can always add on another set of what we call a drop wire. Put a post and put a drop wire here, making it more stable. You can even put a shunt spin, and you can even put it at different angle to increase the rigidity or the stiffness. And since pin fixator like this, the ring fixator, you can try to put it an angle 90 degrees if possible to increase the stability. More central better, less offset. You can even use olive wire. Olive wire, if you have not seen, this is how it looks like. There's a bead here, and it will stop it here. You can imagine if you stop the bone here, and here it can reduce the shear forces. This tibia is not going anywhere in terms of shear force. All right. Theory sounds nice lah. Don't forget the biology, the safe zone. It is not always possible to get 90. In between 30 to 90 degrees is acceptable. This is within 30 to 90 degrees, then it's okay. A little bit, we're finishing here, a little bit of fracture healing with exfix. Because exfix usually is not definitive, we don't really talk about fracture healing. But in the instance where you use it for definitive, usually or almost always it is a secondary healing because of its relative stability. Of course, biomechanically, it always depends on the rigidity of the construct. The more rigid, the more primary healing. And the same, too rigid, also no healing, or too loose also, it won't heal also. So sama lah macam our internal fixation. A bit of a point with comminution, if less comminuted or like a transverse fracture, more prone to a displacement or non-union because it doesn't share the load whenever you are loading the bone. If you have a comminution, it is nicely distributed, hence it is more favorable for healing. One thing about fracture healing is we can have the concept of dynamization because of the V1 micro motion. Dynamization meaning we encourage activity in a patient with exfix, and if you deem it safe, you can increase weight bearing, and you can progressively dismantle the frame as you follow up the patient by reducing the pin ke, by removing some clamp ke, or slide slide clamps away to make it less rigid, and you ask patient to step, so hoping with the patient punya feedback will step only adequately in order to promote fracture healing when you load the bone, because the bone is alive, isn't it? So we load it, it will heal better. Okay, so these are the gist of my talk. Focus again on the factors affecting the stability of exfix construct. These are my references, and I thank you for your attention.